Hey friends, listen carefully. BNF Chapter 1, Part 9. These topics look small in the book, but in exams, they hit hard. Rectal and anal disorders and anal fissure. Short topics, tricky questions. One wrong line, marks gone. Stay focused, because today we clear the confusion. First, ask yourself a simple question. Why is passing stools painful in some patients even when there is no infection? The answer is often anal fissure. An anal fissure is a tear or an ulcer in the lining of the anal canal, just inside the anal margin. It is not deep, but it is extremely painful. Clinical features, remember these clearly: bleeding, persistent pain during and after defecation, a linear split in the anal mucosa. This pain can last for hours. That's why patients are afraid to pass stools, and that fear makes constipation worse. A vicious cycle. Aims of treatment. Before jumping to drugs, always ask, what are we trying to achieve? The aims are simple: relieve pain, promote healing of the fissure. Nothing more, nothing less. Now let's talk about drug treatment of an acute anal fissure. First, remember one very important thing. An acute anal fissure means the problem has been there for less than 6 weeks. So this is an early stage. And in early stages, we do simple but smart treatment. Now ask yourself this question: what is the real problem in acute fissure? It is not infection. It is not inflammation alone. The real enemy here is hard stool. When stool is hard, the patient strains. When the patient strains, the tear opens again. And that is why pain and bleeding continue. So, as a good clinician or a good pharmacist, your first rule is very clear. Make the stool soft and easy to pass. This is pure BNF thinking. Fix the cause first, not the symptom. So how do we do that? We start with bulk-forming laxatives. These increase stool bulk and softness naturally. A classic example is Ispaghula husk. If that is not enough, or if the stool is still hard, then we add an osmotic laxative. A common example is Lactulose. These drugs pull water into the stool, making it softer and easier to pass. And once the stool becomes soft, the fissure finally gets a chance to heal. Now let's talk about pain. Patients often complain of severe burning pain after defecation. For this, we can use a topical local anesthetic, for example, lidocaine. It numbs the area and gives relief. We can also use simple analgesics like paracetamol or ibuprofen, but listen carefully. These are only for short-term use. They are for comfort, not for cure. Now comes a very important exam point. Please don't miss this. If stool softening measures and pain control do not work, do not keep adding medicines again and again. That is wrong practice. The patient must be referred for specialist treatment. BNF is very clear here. Treat simply, treat logically, and if it fails, refer early. That's how you manage acute anal fissure properly. Now we move on to the tricky part. This is where many students get confused. So listen carefully. We're now talking about chronic anal fissure. Chronic means one simple thing. The fissure has been present for 6 weeks or more. At this stage, the pain does not settle. And more importantly, healing does not happen on its own. Why? Because the internal anal sphincter remains tight. Blood flow is reduced, so the fissure just refuses to heal. So now, stool softening alone is not enough. We need drugs that relax the anal sphincter. The classic first-line drug here is glyceryl trinitrate, also called GTN, used as a rectal ointment. The usual strengths are 0.2% or 0.4%. Now here comes a very important exam word. GTN is used in an unlicensed manner. Mechanism is simple and beautiful. GTN releases nitric oxide that relaxes the internal anal sphincter, blood flow improves, and healing finally starts. But BNF is very honest about GTN. Healing is only slightly better than placebo, so it is helpful, but not magical. And yes, headache. This is very common. Around 20 to 30% of patients get headache. Also remember this line clearly. Recurrence is common, another exam trap. Higher strength GTN means more side effects, especially more headaches. This is classic BNF language. Now let's talk about something very important, the alternatives to GTN, because many patients simply cannot tolerate GTN. If GTN causes severe headache or the patient stops using it, we move to calcium channel blockers. The most commonly used option is topical diltiazem 2%, again, unlicensed use. Another option is topical nifedipine, usually 0.2 to 0.5%, also unlicensed. Why are these drugs preferred by many clinicians? Because they relax the sphincter with fewer adverse effects, less headache, better tolerance, better compliance. Now you might ask, can we use oral nifedipine or oral diltiazem? Yes, they can work. But remember this clearly. Oral forms cause more systemic side effects like hypotension, dizziness, flushing. So in practice, topical preparations are preferred. Now comes the final step. Very important. If all first-line medical treatments fail, do not keep switching creams endlessly. The patient must be referred to a specialist. One important option is botulinum toxin type A injection, again, unlicensed use. What does it do? It reduces sphincter tone temporarily. The muscle relaxes, blood flow improves, and the fissure finally heals. So remember the logic. Chronic fissure needs sphincter relaxation, not just painkillers. If you understand this logic, you will never forget this topic. Now let's briefly talk about non-drug treatment of anal fissure. And yes, this means surgery. First, understand this clearly. Surgery is very effective. In fact, it has one of the highest healing rates for anal fissure. But, and this is very important, surgery is not the first option. BNF is very clear and very strict here. Surgery is reserved for chronic anal fissures, not acute, not early cases. And even in chronic fissure, surgery is considered only when drug treatment fails. Why? Because most fissures can heal with conservative management, with stool softening, with topical drugs, with sphincter relaxing agents. BNF always prefers conservative management first. Surgery comes last, not because it doesn't work, but because it carries risks. So remember the order. Start simple, treat logically, escalate only when necessary. That is exactly how BNF wants you to think. Now let's move on to another absolute exam favorite. And yes, this one comes again and again. We are talking about hemorrhoids, also called piles. First, let's clear a very common misunderstanding. Hemorrhoids are not veins. Please remember this clearly. Hemorrhoids are abnormal swellings of the vascular anal cushions. These cushions are normal structures. They help with continence, but when they become enlarged and symptomatic, we call them hemorrhoids. Now let's talk about types, and this is a must-remember area. First, internal hemorrhoids. These are located above the dentate line. Because of that, they are usually painless. Patients may notice bleeding, but pain is not common. Pain occurs only if the hemorrhoid becomes strangulated. Next, external hemorrhoids. These are found below the dentate line. Here, pain is common. Patients may also complain of itching, discomfort, or irritation. And don't forget this important clinical point. Pregnancy increases the risk of hemorrhoids. This is very important for exams and practice. Now let's think like BNF. What are the aims of treatment? The goals are very simple and logical. We want to reduce pain, reduce bleeding, reduce swelling, promote healing, and most importantly, prevent recurrence. Now, before touching any medicine, BNF always asks one question. Can we manage this without drugs? So let's start with non-drug treatment. This is always the first step. Increase dietary fiber, increase fluid intake, improve perianal hygiene. Why does this matter? Because less constipation means less straining, and less straining means less symptoms. Many patients improve just with this. Now let's move to drug treatment. First question, again, is the patient constipated? If yes, treat constipation first. BNF prefers bulk-forming laxatives. They soften stool naturally and reduce straining. Now pain relief. Paracetamol is safe and preferred. Avoid opioids. Why? Because they cause constipation. Avoid NSAIDs if bleeding is present. Now let's talk about topical preparations. These are very commonly used, but BNF is very honest about them. They may contain local anesthetics, corticosteroids, astringents, lubricants, or antiseptics. They give symptomatic relief only. They do not cure hemorrhoids. And remember this exam line clearly. No topical preparation is superior to another. Now, a very important warning about local anesthetics. Examples include lidocaine, benzocaine, cinchocaine, and pramocaine. These should be used for a few days only. Why? Because they can cause sensitization. Rarely they can be absorbed systemically. And if overused, they can actually worsen irritation. Next, corticosteroid combinations. They help by reducing inflammation. But remember this clearly. They do not reduce swelling or bleeding. Use them for no more than 7 days. Always exclude infection first. Long-term use can cause skin thinning, ulceration, and even adrenal suppression. Now comes the referral part. Very important. Refer the patient if there are recurrent symptoms or if there is failure of medical treatment. Specialist options include rubber band ligation, injection sclerotherapy, infrared coagulation, hemorrhoidectomy, stapled procedures, and hemorrhoidal artery ligation. Finally, let's talk about hemorrhoids in pregnancy. Very important area. Bulk forming laxatives are safe, but remember this clearly. No topical hemorrhoidal products are licensed in pregnancy. If treatment is needed, use simple soothing preparations. Avoid local anesthetics. Avoid corticosteroids. Always keep treatment gentle and minimal. That's hemorrhoids. Explained clearly the BNF way. So friends, that's it for today's topic. If you understood this video, you're not just memorizing, you're thinking like a clinician. And if you've reached here, let me tell you something honestly. You're addicted to learning properly, and that's a good addiction. Now, listen carefully. The next video is the last video of BNF Chapter 1, and the topic is stomach care. Don't miss it. If this video helped you, like the video, subscribe, and continue the journey. I'll see you in the final Chapter 1 video, stomach care. Keep studying smart.